Physical distancing, face mask, and eye protection to prevent person-to-person transmission of SARS-CoV-2 and COVID-19, a systematic review and meta-analysis. Introductions. As of May 28, 2020, severe acute respiratory syndrome coronavirus 2 (SARS-CoV-2) has infected more than 85 million individuals worldwide and caused more than 3,079 deaths. Emergency lockdowns have been initiated in countries across the globe, and the effect on health, well-being, business, and other aspects of the daily life are felt through societies by the individuals. With no effective pharmacological interventions or vaccines available in the immediate future, reducing the rate of infection, flattening the curve, is a priority, and prevention of infection is the best approach to achieve this aim. SARS-CoV-2 spreads person-to-person through close contact and causes COVID-19. It has not been solved if SARS-CoV-2 might spread through aerosols from respiratory droplets. So far, air sampling has found virus RNA in some studies, but not in others. However, finding RNA is not necessarily indicated of the distance. The distance from the patient that the virus is infected and the optimum person-to-person physical distance is uncertain. For the currently foreseeable future, until access an effective vaccine or treatment becomes available, COVID-19 prevention will be continuing the early or non-pharmaceutical interventions, including pandemic mitigation in community settings. Thus, quantitative assessment of physical distancing is relieved to inform safe interactions and the care of patients with SARS-CoV-2 in both healthcare and non-healthcare settings. The definition of the close contact of potentially exposed health risk, strategy, contact trace, and the development guidances documents, but these definitions differ around the contain will spread infection and reduce the mortality and mortality among healthcare workers and others in contact with the potentially infected people. Jurisdictions have been sued conflicting advising about physical or social distancing. Use of face masks with or without eye protection to achieve additional protection is debated the mainstream media and by public health authorities. In particular, the use of face masks for the general population. Moreover, optimum use of face masks in healthcare settings, which have been used for decades for infection prevention, is facing challenge aiming personal protection equipment. Any recommendations about social or physical distancing and the use of face masks should be based on the best available evidence. Evidence has been reviewed for another respiratory viral infections, mainly seasonal influenza, but no comprehensive review is available of information or SARS-CoV-2. Or related beta coronaviruses had caused epidemics such as severe acute syndrome virus of Midwest in 22. So, outcomes of interest were risking of transmissions e who define confirmed or probable COVID-19, SARS or MERS to people in healthcare or non-healthcare settings by those infected, hospitalization, intensive care unit admissions, death, time to recover, adverse effect of interventions, and context factors such as accessibility, feasibility, effect on equity, and resource consideration related to the intervention of interest. However, data were only available to analyze interventions' effects for transmission and contextual factors. Consistent with WHO study generally defined confirmed cases with laboratory confirmation with or without symptoms, and probably causes with clinical evidence of this respective inspection. Results: We identified 1,072 studies for our systematic review from 16 countries across 6 continents. Studies were all observational in nature, non-randomized, trials were identified of any interventions that directly addressed the included study populations. Of the 172 study, 66 focuses on how far a virus can travel by comparing the associations of different distances on virus transmissions to people. So